Hello, I'm Ronnie Eldridge. Welcome to Eldridge and Company. My guest today is Dr. Louis Goldfrank. He is an international leader in the field of emergency medicine, and for more than 30 years, the Director of Emergency Services at Bellevue Hospital Center, NYU Langone Medical Center, and the Manhattan VA Medical Center. And he's a very busy man, but I imagine very fulfilled.
Yes, it's a pleasure to work every day when you can try to save someone's life or to help them understand what their life should become.
And it is such a wide variety of people.
I think people love that.
Causes, yeah.
Love that because when you walk in the door, you know you're going to work at the UN every day. Every country is represented, every idea is represented, and we have to learn how to communicate with people. It's
amazing. Before we go on to talk about emergency medicine and more, can we talk a little bit about Ebola?
Ebola is a big topic.
I remember, at least I think that I read in the paper, that you were just returning from Africa when Dr. Spencer showed the symptoms.
Yes.
And came to Bellevue.
So we have had a relationship between NYU and Bellevue and the University of Ghana as its medical school and the public hospital in Accra, Ghana for 6 or 7 years, almost 7 years. And we have faculty there. And I go back and forth several times a year, many of our other faculty and residents and nurses and staff. And what we've found in the last visits that there's an amazing fear of Ebola. There are no cases in Ghana, but the consequences of the potential for that are devastating for the community. People don't have enough of the things we consider personal protective equipment to protect us from the virus, either enough gloves or enough masks or enough protective shields. And so we went, we had collaborators at NYU, and we had some people we negotiated with in Ghana to get personal protective equipment for the staff there. And we began, our staff have worked to try to teach people how to protect against tuberculosis, how to think about these things and change the way emergency care was done. So it was ideal for us to go, it was necessary, because we had to give people faith that they could resist this terrible plague.
And then you came home to, we have an argument all the time. I consider a lot of hysteria that shouldn't have been there. Do you think I'm wrong?
I think that for many of us, when I first started at Bellevue in 1979, the plague then was what we called gay-related immunodeficiency disorder, what was later to become called AIDS. And many people, when with the unknown, don't respond well. So we need the concept expressed by someone who's accepted in the community. I think in New York we had David Axelrod, who was Commissioner of Health. And we had Mario Como, who helped in this process, and we ultimately had Coop. We had a great messenger who could be believed, and we had a message that people could understand, and we transformed the way we viewed that. We didn't have that for America. There was an awful lot of confusion, and that's what we need to achieve. I mean, people at the CDC are pretty wonderful. Anthony Fauci's pretty wonderful. A lot of people who do it, but everybody said his or her own thing. You can't treat people the way they were going to treat returnees from working, saving lives in Africa, and you can't treat people with such limited knowledge that they can't function effectively, and we needed help.
What would you, I mean, to have run the emergency services at that hospital and have that happen there, it must be very foreign to you. I mean, that could never happen at Bellevue.
No, I don't think that we've been preparing probably for everything. We've been through most of the big events. You know, they bombed the World Trade Center twice. We've had this epidemic. We had the anthrax events. We've had terrible new diseases. We're ready for things. We've talked about this. We've been talking about Ebola for quite some time when we try to prepare for biological and chemical terrorism. We've written documents about things like this. We try to think about it. We never have enough to do everything perfectly, but we had lots of things and lots of systems that do things very well. For example, the Bellevue Emergency Department, since the AIDS epidemic and the TB epidemic, has had the kind of ventilation that gets rid of the air. No air is recirculated. It's all put outside to the general air. We try to have rooms that are very protective, isolation rooms, so that we try to teach people to think the biggest problem for you today might be influenza. Get your vaccine, get your shot. It's essential. We don't let doctors and nurses and clerks and anybody come to work without it. We've got to get people to believe that. There's almost no chance of getting Ebola, but 30 or 50,000 Americans are going to die of influenza this winter.
You know, one of your interests is humanism in the need for respect and contact and trust between patient and doctor. What I thought of immediately when I thought of the Dallas hospital was, how could somebody, so the nurse didn't pass on that he had just come here, but how could anybody have released him when it was obvious he was not from here, not from this country? It is just that you don't pay enough attention to the patient?
Well, I don't know the facts.
No, I know
that. But I would say
that's a very important concept for
critical. The nurses at Bellevue and at NYU and probably 99% of the hospitals in America are taught right now. There's a big map of Africa. It shows where Sierra Leone is. It shows where Liberia is. It shows where Guinea is. It asks you in French or in English to get the information. Use a translator phone if you have to find out, have you been in one of these countries? Have you worked with someone who has this disease? Do you know anything about it? If you're uncertain. So people do put into this isolation room. They're walked right from the triage desk with almost no time, seconds to minute. Within a minute, they're in an isolation room where we can talk and get more detailed information. But the first screening is really to see what country. We do profile those countries. Then it doesn't matter who you are. If you've been there and worked there, you want to find out the information. Then you want to make sure you're helping the person. You tell the person why we're doing this. You try to establish a fine relationship. You try to then get enough information to be able to say, this man may come from Liberia, but it's an enormous country. He has had no contact. He stopped there for one day. Or he's a man who's lived in America for 20 years and does come from Liberia, and he came at that point. So get the story straight, get the information straight, ask what's wrong with the person. Most of the people we've had who've come from West Africa, who've been brought into that isolation room, have the typical things. They have malaria, or they have typhoid, or they have some disease that we all have, and so we try to help everybody. But we get the information, then we treat everybody the way they should based upon the disease and the risk they have.
Emergency medicine, let's talk about that now. It covers so many different areas, doesn't it? And you were one of the first people that became a specialist in it?
I am. The first exams were in 1979, and there were a number of us across the country who had begun to work on this process. To me, it was a way to do care for people that couldn't get care in the past. There were no emergency departments. The ambulances weren't yet developed. They weren't the kind we have now. They looked more like hearses, so they could function in both ways. They didn't have people who were trained. There were no paramedics. We trained the first paramedic classes in the early 1970s.
They used to rotate doctors who were affiliated with the hospital. 1 week this one, yeah.
And they didn't have people who could really do things that were necessary. To put a tube in the throat, cardiopulmonary resuscitation and defibrillation were all new. So that these were things that the body of knowledge wasn't developed. They were all developed in the Nixon administration, these 1203 grants for the future of emergency medicine. That's how we developed funds for the Poison Center here in New York. You know, that many of these things were amplified, improved upon because of federal funding. And this changed the way emergency medicine could be done. And then it attracted people who love to talk to patients, love to listen as well, substantially to patients, love to be able to help people in the moment of need. And it began to create a system that continued from the street to the emergency department, hopefully onto the outpatient department to get primary care, hopefully into the hospital for fewer people, into the ICU. But we were glue that had been missing to some extent, and we changed the way people cared for individuals.
And you extended access to health care.
That's right.
To so many people. How is the new health care arrangement, the Obamacare, how has that affected?
Well, our hope is that we certainly have more people in the outpatient department. We have ways to facilitate getting people into the outpatient department. Our goal would be that if you have what we call an ambulatory care sensitive disorder, someone who's got diabetes or hypertension or asthma or congestive heart failure, you move them directly from the emergency department to the outpatient department in a couple of days so they get stabilized, so they don't have to be admitted to the hospital. We did actually, when I worked with Martin Cherkasky and a woman named Mucha San Augustine in the South Bronx, in the 1970s, we opened a neighborhood family care center adjacent to the emergency department. And we had doctors and nurses, nurse practitioners who spent one day in the emergency department, the next day in the outpatient department, back and forth, and they took their patients there. And in a matter of several years, in the midst of the South Bronx in the 1970s, we saw a dramatic fall in admissions to the hospital for asthma, congestive heart failure, diabetes. It's the same system reborn now. It's exactly what we have to do to get people reasonable care expeditiously.
And it's also, I mean, you're practicing public health.
That's right.
Yeah.
Sometimes we call it this, over all of us is this population health. When I see a person, it's the link between a human being and this whole population. And so it's practical, very practical public health. And so when I see a person, I say, what's the lesion in the public health system that brought this human being to this department today? No one should have to come to an emergency department. If the world were good, all the people would have these things prevented. We think that there is no such thing as an accident. Things happen, but they have an etiology. We need to know the social determinant. What forced this person to have to come to me as opposed to getting to a primary doctor, or as opposed to staying home? How do we prevent these things?
So you see the problems.
That's right.
And you also see the needs. I mean, aside, I don't mean, I'm sure they're similar, but it's like certain number of things happen, then you know that has to be moved up on the priority of finding the solution.
This morning, I interviewed new residents for next year at Bellevue Hospital in NYU. I asked them to say, look at those patients. I want you to find some problem that you think you can solve, and to make that your career, your devotion. Find a problem to solve, some critical flaw in our society that you need to correct. Be a revolutionary, change care so people can get better lives out of it, and give them the opportunity not to suffer from this problem that you've seen. I have a young woman who's working with us, who did a residency with us, been devoted to homelessness for her whole career. So she's a young woman, just finished a Robert Wood Johnson fellowship, but she's trying to prevent homelessness. Not to try to treat it once it occurs, but look beforehand and do this. We have people who are saying, let's get more supportive care for our patients who come in with congestive heart failure, or maybe liver failure or cancer. Not everybody needs everything done, but in terms of an operative procedure or a new chemical, but everybody needs the humanism necessary to get through this disease and be supported better in a reasonable fashion. So think of a way to change that meets the patient halfway. Remember, for us, we see more than 100 different nations represented every month in the emergency department. So what is their cultural need? What's their health literacy? What's their health numeracy? We've got to know all those things. We've got to find the right mechanism to get them the right kind of care that they need.
So, and it's constant training also, isn't it, to be able to find those things?
That's right.
So there are different areas that you have to be sensitive to, right?
I think you have to, we want people to read the New York Times every day. We want them to listen and read books, and read Gawande or Verghese, or read things that are distinctly different. Understand art. Go to the Met or go to the MoMA to really see the way other people express ideas, and think about talking to the people on the street and in the emergency department. So you get a vision from all the stakeholders involved in anybody's care. What are they thinking about? What's their country thinking about? What's the poverty? What are the issues? It's never ending. As long as you have a chance to listen, you have a chance to learn and improve the care.
How did you become this person? I'm always interested in knowing what happened to make a person so socially conscious and also so fast. I mean, how did you get to be you?
Probably I had good parents and grandparents.
Where did you grow up?
I grew up in Westchester, in a place called Thornwood.
So you always had a social conscience?
My parents were very actively involved their whole lives, very politically active.
That's so important, isn't it? The environment in which you grew up.
I met lots of people with different ideas, and there weren't absolutes. There were lots of relatives, and there were lots of strong values. You had to be good to every single person. You have to think through from an ethical, humanist point of view how you dealt with things.
Yeah.
But you also had to reflect upon the things we didn't know. And the idea that we talk very philosophically about Heisenberg, but the uncertainty principle. We never know definitive answers about lots of problems. There aren't things, A, B, and C doesn't always equal the same thing in our setting. And we've got to think about the unknown and be satisfied with that, to think further about solving big problems.
So do the residents and interns that work with you come out of that training with the same sensitivity?
I think that's why they come. So people, when you walk into our institutions and you see how complex it is, we like people to come and see us. And we want people to be scared away. We want people to come with passion and mission and vision so they can get the best education in the world.
Right.
And they all go away being, I think, very gifted. But they were very well selected. We have 1,000 people apply for 15 places. So we get a lot of people who are just great.
Amazing. It really is. There's a big men's shelter right near you.
Yes.
What do you do? Are they involved with you?
Oh, many of them come to us for care. Many of the systems we work on try to facilitate to improve their lives and care. Lots of projects working on figuring out how someone who's already homeless and is in difficult shape can get better existence. So we think that the people who have many visits to an emergency room, or too many visits to an emergency room, are a problem. We try to get them in the outpatient department. We try to get them into a home and say that if they've got 100 visits to the emergency department over a year, that costs a lot of money. If we get them a home and get them in a place where it might still be wet, it might not be a dry home, but you get them there and you get someone to work with them to get them into the outpatient department, you prevent that person from ending up in jail or ending up in the intensive care unit or ending up with an operation. So you've saved society a lot of money, you've helped a human being, and everyone can be happy. You can find solutions that integrate distinctly different values of life.
So I'm just thinking of the progression, the need for more housing, the need for parenting skills.
Yes.
The need for peace in families, right? All of these things all connect with you, but how do we do it so that we can provide those extra services so you can make all these people who come to the emergency room patients in out service?
Well, you got to be an optimist.
Outpatient.
You got to believe, the quote I often was taught and use, I think the Red Queen said to Alice, you've got to believe at least 2 unbelievable things before breakfast every day. That's what we tell people about coming to Bellevue to work. You've got to, I want people who will find a problem and want to solve it. I have a young woman who were a young attending and a young fellow in toxicology attending who's done global health. We're trying to work on a strategy for getting education out to the students in schools. We'd like to say that medical students and residents and faculty should go to the public schools and be involved in bringing a new form of health education, health literacy, and health numeracy. One, to teach doctors and of all sorts and nurses how to speak to students and understand what the community needs, and how students can then help each other and bring something back to their family.
Now, how do you affect public policy? Because obviously you do. When I worked for the mayor, Mayor Lindsay, there were doctors who came to say that we must do something about lead poisoning. Actually, there were agitators outside, the young lords. And we totally changed the procedure for lead poisoning. So there is a very close connection, isn't there?
Absolutely.
Do you do that?
Absolutely. Many domains.
Yeah.
So we can look at the New York City Poison Center as an extension of that. That's been in existence since the 1950s.
You're the director of the Poison Center.
But I have lots of exceptional people who work there, and that what we do is we try. I'm the medical director. There are other types of directors. I sort of have stayed on in a role that helps others. But the objective is to say we can prevent children from having to leave their homes to come to emergency departments if we have a great phone system and communicate with them and penetrate into the various communities so we can do it in multiple languages. But to say, what is the problem on the telephone? That's not so serious. You don't have to worry about it. You can call us back, but we'll call you back in an hour. We'll call you back in 2 or 3 hours to make sure it's safe to stay home and not go in. So we save a tremendous amount of money by reassuring people that the pill they got into isn't so consequential, and that Johnny can stay home. Johnny doesn't have to rush in there. You don't have to go by ambulance. You don't have to wait in the emergency department and get influenza. Stay home. And we try to do that, and that's how we show the city and the federal government that you save a tremendous amount of money by having a poison center. Make it exist. It saves 10 million, 20 million in some cities dollars of not wasting bringing people to the hospital.
So do we have neighborhood health centers enough?
We have a number of them.
We have enough?
Well,
is that the network that you also
that's right
go through?
Well, we do. There are many neighborhood health centers. You know, the outpatient department at Bellevue Hospital has almost 500,000 people seen there.
Yeah.
So many at the big public hospitals, at many of the private hospitals, many people are being seen. The objective would be to have every single person have a health insurance like Medicare.
Yeah.
So that they don't have to worry about this, and we protect them, and we believe that we're going to prevent.
So we're talking about a single payer system?
That's right. It's the only solution to the big problems we have.
But you know, when I just talked to somebody about policing, and then you talk to people about recidivism from prison and what you do community-wise to do this, we're always talking about organizing a community. And the question, I guess, the challenge is, how do you bring it all together? You know, when you're talking about an ex-prisoner, or you're talking about a kid that. The whole thing.
Well, the stakeholders have to be there.
You're so important for that.
You have to get leaders of a community, leaders of a government there. They have to get all the stakeholders together.
That's where your optimism comes in.
That's right. Because I think if you get people together, this meeting I ran with several of my friends from New York University, we got all the community together in Accra in Ghana because we said this is a critical time We all need to work together to understand how to solve the problems, to get people to stay at work, believe that it's safe, get things going so that they can do the things that are essential to keep themselves safe, to retain the good doctors and nurses there. And we met for several days working on these issues and pulled together a system that they thought was wonderful, we thought was wonderful, we all learned, but it was a way to help. And we have to do that kind of communitarian effort here in New York City.
And we do it all, and you're doing it around the world.
We have done it, but
do you do it through, did you just do that with Ghana? Does it go through the United Nations? Is there any way of doing that?
We have had a relationship with the University of Ghana for some time, New York University and the University of Ghana and the two big public hospitals. We've had a lot of efforts. I have staff there who work for NYU and work there for the University of Ghana and the public hospital. We met with people from the UN. We had several anthropologists in the group. We had doctors, various types of science, public health people, government people, and really we're listening to what the people needed. What do the people think? How do you do it? And we need to do that in all of our cities, in our country. And you have to, we have a problem that there are too many voices and there are not enough coherent voices working together.
So you're going to stick with Ghana? You're going to go someplace else too?
I have a responsibility there for the moment, and it takes a lot of energy, and it's good to have a lot of our staff because it makes a big difference, I think, for healthcare here because they understand what immigrants are like. So
the question of palliative care, you must face that in the emergency room.
Every day.
What are we going to do about that?
We have to do very well at it. I would say most of the people I work with, a woman named Karita Grudzen, who works on our staff to try to work on improving what we call supportive care, because everyone needs supportive care. It might be that you get the support you need for your disease and understanding, and someone who understands, who listens to you, gives you back a response, then listens again as you make your response, sort of an iterative process to understanding what care has to be. But it's supportive and it's palliative, it offers both. You've got to make sure that the person's living a life that is meaningful to that person for the time that he or she will live. And we all have some finite end to this process. And so don't worry about, you can give palliative care and you can give what might be necessitated at a more aggressive or interventionist, new chemical, a new radiologic, but you have to make sure the patient understands how to get the best and the most meaningful days out of the rest of his or her life.
And how does that differ from hospice care?
Well, hospice is one phase of the process. You could have...
It's just one of the...
You could have... I could be known to have a disease today. I want someone to support me while I continue to do my job or where I cultivate my garden or whatever I'm going to do. And that kind of support, I don't necessarily need to be in hospice at that stage. I'm able to do my normal activity. But early on, recognition should be you have a problem that's consequential. It means you're going to die at some point in the future. And you want to make sure that the decisions you make now and the way you get care and the things you adjust to and talking to other people are based upon a rational understanding of what this disease might mean.
It's a very difficult thing, isn't it? We have a young friend whose mother had a stroke and he has no relatives, so he was responsible basically for what to do, and he decided not to do anything except to make her comfortable. And the guilt and the after part of it is so difficult for him because somehow we're changing. There's a great change, I think, isn't there, in the public's perception of what should be done and
I don't know if
what the quality of life is?
Yes. Well, I think as an emergency physician, when I started, I think we believed resuscitation was new, intensive care units were new, and maybe we thought we could do almost anything. And over time, we've learned that we do too much sometimes, we do too little other times, and it's how to find the right approach. And this new book by Gawande was really a beautiful effort, Being Mortal. And so he really takes some time in this evolution and to begin to understand these issues and the things that are necessary to do for people at various stages of disease, to make sure that the patient is getting the best out of it for himself or herself, and not conceptually what's best for the doctor or what a protocol might do, but what that individual human being and his or her family needs.
And this is now reflected in training of doctors?
Absolutely. Yeah. We do it, I would say I work in the emergency room a couple times a week. Every single shift, we have several people who we begin the discussion. Someone who can't deal with the strategies that others have, someone who finds a new way to deal with it and feels much better. We help families, even from the emergency room. We don't know the person well, but we know some of the problems. We do the talking, we get started, we get the people from palliative care to come and talk or supportive care to come and find new solutions for what is obvious that all of us recognize have to be done at the right time. It's talking through the issues that are sometimes too complicated to do under other circumstances. And people reach the stage, their tipping point for understanding that maybe this isn't right any longer, or what would be right, how to discuss it, to find good people who are open to it.
Yeah. Do you actually teach classes?
Sure. That's
at the medical school?
At the medical school.
What does that mean?
Well, the classes are taught sometimes at the bedside, sometimes they're in a simulation unit, sometimes they're in a laboratory. I teach sometimes about preparedness. We teach a class in toxicology several times a week, or a big class at the Poison Center we've been doing for 40 years. The first Thursday of the month we teach for 2 hours, and we mix students from pre-hospital care to pediatrics, anesthesiology, medicine, emergency medicine, pharmacy. They're all together, and we talk about the 10 toughest cases of poisoning that occur in the Eastern Seaboard every month. So we find ways to talk to people, mix of people, because you need a mix of people to care for individuals. And sometimes out of that, we say that person's got to be, the person who gave that person that medicine or that strategy has to be reported to the health department. That's not logical. Sometimes you say that's a wonderful job. Sometimes everyone learns a new strategy. So getting people together of diverse perspective is essential to succeed and understand. We've
come to the end of this program. I've thoroughly enjoyed it. I could go on listening to you for a long time. I'm so pleased that we have you in this city, and I thank you.
Thank you very much. Pleasure to be here.
If there are any people you'd like to hear and topics you'd like us to explore, please let me know. You can write to me at CUNY TV, 365 Fifth Avenue, New York, New York, 10016, or you can go to the website at cuny.tv and click on Contact Us. I look forward to hearing from you.